everybody. Welcome to this webinar. My name is Anne-Mees and I'm your moderator for today. Our lecturer is Stijn Vervaeke. Welcome, Stijn.
Thank you, Anne.
Dr. Stijn Vervaeke received his dentistry degree from the University of Leuven in 2007 and continued his specialist education in periodontology and oral implantology at Ghent University and finished his PhD in 2014. Dr. Vervaeke combines a private practice with a position as associate professor in the bachelor master program in dentistry and the specialist program periodontology and oral implantology at Ghent University. His research focuses on alveolar ridge preservation, soft tissue management, and prevention of peri-implantitis. He published in international peer-reviewed journals, lectures at international and national conferences, and is president of the Flemish Accreditation Committee Periodontology. First, I would like to thank Stijn for giving this webinar, and for all the people who are listening to this webinar. If you have any questions, you can put them in the Q&A. I wish you a nice webinar.
Okay, thank you, Anne, for this nice introduction. All right. So I hope everyone can see the screen. So the topic of this webinar is the importance of science, and I will try to share with you in the next hour the evidence-based clinical practice in oral implantology and the evidence behind the AstraTech implant system. So this is a very nice paper that was published by let's say 3 heavyweights in the world of oral implantology, and Daniel Buser, Lars Tenderbu, and Hugo de Bruyn, and gives an overview of modern implant dentistry and the history of 50 years of research. So osseointegration was invented in 1952, was discovered by the late Perrin van Brennemark, who wanted to study vascularization in the tibia of rabbit models, and once the experiment was over, he tried to remove the optical chambers which were made out of titanium from the tibia of the rabbits, and he saw that they were integrated. So he started thinking about possible clinical indications for his discovery, and he thought immediately about edentulous patients. So what he didn't know, that was at the same time that Professor Schröder in Switzerland, in Germany, he discovered more or less the same thing. But he continued with rough implant surfaces, and later on it was possible to place implants in a one-stage procedure. And then it never stopped, right? So we basically can have a look at the beginning, the beginning of osseointegration, which was more or less the scientific quest for osseointegration, and then we made a major shift from the 80s till 2000. Was let's say the period which was a period of major progress in the field of implant dentistry, where we started to treat partially edentulous patients, where we started to think also about aesthetics. The shift from machined surfaces to moderately rough surfaces was really key in this advancement. So we made the shift from submerged to non-submerged healing, from delayed loading to immediate loading, and later on even immediate placement. So the period thereafter, the next 10 years, we can consider that more or less as the fine-tuning phase in implant dentistry. And nowadays we are focusing more or less on patient-centered implant dentistry, soft tissue management, and aesthetics. And of course, now we have the shift towards digital dentistry, which I will try to show you during this lecture as well, how that has changed the way we are treating our patients. So the good old days, I remember Hugo de Bruyn telling me that in the old days, sometimes, you know, patients were anesthetized, the flap was raised, and after raising the flap, they saw that there was not enough bone available to install implants. So flap was closed and patient was sent home again. So today, this is completely unacceptable with everything that's available to make a proper planning. But also in the old days, the position of the alveolar nerve was determined based on panoramic images. So sleepless nights and a lot of stress were part of an implantologist during that days. So today we use modern day treatment concepts, as is shown here in Azento case, where we combine intraoral scanning techniques with CBCT images, where we can make a perfect plan before the treatment starts, and restore our patients in a very secure, a very predictable way, and where we can reduce chairside times tremendously for our patients. So why do I work with Dentsply Sirona implants? Well, I must say that I've got my training using Astrotech implants. Also, all my research was focused on this particular system. And at Ghent University, we have a very nice collaboration agreement with Dentsply Sirona. They are working together with over 90 universities worldwide. And they have a really a big budget they spend on an annual basis that they invest in clinical research, which is, of course, extremely important. And I think that the clinical research we are doing at the university, in combination with the innovation of a company like Dentsply Sirona implants, helps us tremendously to in the benefit for our patients. So we have to understand our patients. I will not focus on that point today, but I will focus on the hardware we use, the implant, the abutments, and also on the evidence for us as a practitioner, as a surgeon, as a prosthetic dentist, how we could treat our patients in the best possible way, and how we could try to overcome problems on the long run. So the Astrotech implants, it's
and can I just ask you something? We still see the first slide.
Oh. Let's do this again.
Yes, now we see all your slides. Just have to put it on full screen.
Now he says again, sharing is paused. So you still see only the...
Yes, first slide.
First slide. Wait, let's have a look.
Yes. Yes, I see
this. Is okay?
Yes, I see the second slide.
All right. So
implants.
This was the history. So this I have told you, these were the old days, and this is where we are right now. So the modern day treatment concept. And I was here at this slide. Yes, so I'm sorry for that. I don't know what went wrong, but anyway, we are here. So this is the story of the AstraTech implant system. So you see a lot of evolution that occurred during the years. But what is very nice to see is that the key features of the implant system are still the same. So we have still the same surface, the OsseoSpeed surface. We have a conical connection, we have a platform shift, and we have micro threads. And those key features are still present at the implant today. So the OsseoSpeed implant, which is a moderately rough implant surface, and it's slightly smoother than the previous surface, which was Thioblast. And this is because of an etching procedure with hydroxyfluoride, which will basically result in the presence of fluoride ions on the surface of the implant. And those ions will interact with the calcium ions in the bone of the patient. So you get a mechanical retention, but you also get some kind of a chemically retention of the implants into the bone. It's an implant surface that is integrating really, really fast, which makes it very suitable for demanding procedures such as immediate placement and immediate loading. What's also important is that when you work with a bone level implant, is that we try to transform the two-piece implant into a one-piece implant. And this is only possible with a stable conical connection. This is a study from Broghini where they analyzed bacterial infiltration and in inflammation at the gap, at the micro gap. And as you can see around the one-piece implants, at the level of the bone, you can't really find inflammation or inflammatory reactions, whereas around the micro gap, and let's say that's a 1.5 millimeter distance in every direction in close contact to the micro gap, you find inflammation, and that will result inevitably in bone adaptation processes and bone loss around the implant. And of course, if you use a flat-to-flat connection, please don't install the implant too deep because this will result in bone resorption within 1.5 millimeter of the microgap. But if you want to work with bone level implants, which we are allowed to install it rather deeper in order to respect biologic width, for instance, or to provide enough space for the prosthetic components, then of course you need a stable connection. And if you have a stable conical connection, such as the connection around the AstraTech implant, then you get this. And so you get bone adaptation, bone growth in close contact with or in the close environment of the gap of the connection. So this will not induce bone loss. So this is very important if you want to use an implant in the aesthetic area, that we use an implant with a very stable connection. And I think that those are, let's say, the key features of the AstraTech implant. And of course, a conical connection mainly comes together with the platform, at the platform shift. So as you can see here around this picture. So the scientific background of the AstraTech implant system consists of more than 1,000 clinical studies and experimental studies with over 20 years follow-up. And when we have a look at all studies together, more than 17,000 patients were treated with over 40,000 implants that were followed for up to 20 years. So we know that this is a well-documented system, a very well-documented system that we can use to treat our patients in a very predictable way. We have scientific documentations on small implants, small diameter implants, on short implants, on a very nice study by my colleague and friend, Professor Temmerman from Leuven, from patients suffering from osteoporosis. We have data on immediate loading procedures, on immediate placement procedures. So it's all indications, let's say all clinical indications are very well documented. So the scientific background behind the system is quite extensive. Let's also have a look at the abutments, because as a surgeon, I'm mainly thinking about the implant, but we can say that the abutment might be as important as the implant to maintain long-term bone stability and soft tissue stability around the implants. We already know from the studies from Abrahamson by the end of the 90s that you can't really use every material to restore implants. And I'm quite astonished as today we still see cases where gold or cobalt chrome are used to restore implants. And it's not that long ago that someone was telling me about an EV implant, a 4.8 millimeter implant, which is basically an implant that is that can't break, but it did. It broke. And then we had a look, and someone was already blaming the implant, and we saw the radiographs, and there were just was a cobalt chrome abutment that was made on top of that implant, which was not fitting really well. And then of course you get you don't get a very nice fit, and you get micro damage first, and then you really fracture afterwards. So implants should not be restored with gold abutments or cobalt chrome abutments. There are only two biocompatible materials available that we can use for abutments, and this is titanium and zirconia. On gold, cobalt chrome, porcelain, we don't get attachment of the mucosa. This will cause bone loss, recession, and you will end up with mucosal attachment on the implant surface, so causing bone loss, which will result in exposition of the moderately rough implant surface towards the oral cavity. You will get contamination of the surface, and your implant is at risk of developing periimplantitis. So always use titanium or zirconia in the vicinity of the implant platform. So this is one important point. And today, a lot of innovation has led to different possibilities that we can use, different solutions we can use to avoid cementation. So these are some clinical cases that we saw at Ghent University, where you can see cement excess in close contact with the bone, clinical signs of mucositis. Fortunately, here in those cases, no bone loss yet, which is of course very, very good, as this is a situation that we can solve easily if we remove the cement excess. But once, of course, the bone disappears and we get the true peri-implant disease, then of course it's very difficult to treat in a predictable way. Well, one can say I'm always making a radiograph once the abutment and the crown are installed. However, clinically undetected cement excess is nearly there in all cases. So in 44 out of 60 restorations that were followed in this study, there was cement excess present on the abutment, while it was not detectable on a radiograph. So that means that it's basically impossible to control cement remnants subgingivally. Now today we have angulated screw access available in Atlantis abutments, which makes it possible to angulate your abutment, let's say 30 degrees or even a little bit more. So I mean, it's absolutely not necessary anymore to cement the crowns on top of the abutments. And this is, of course, a major improvement, which is absolutely evidence-based, where we can really prevent a lot of peri-implant disease. So it's not only about the avoiding cementation, but what's also really important is the abutment design. There's a lot of evidence available today that the implants, the abutment design should be concave, not be convex. And the scientific rationale behind that is that biologic width is a three-dimensional thing. It doesn't work only in vertical dimension or in horizontal dimension. It works in every direction. And a convex design, abutment design, will squeeze the soft tissues towards the bone, and the bone will disappear. This was very nicely shown here in this study, but also in this study by Kutuzis, where he compared the two designs. So on the left side you see the convex design, on the right side you see the concave design, and they saw statistically significant more bone loss around implants that were restored with convex designs. This is something, if you look at the Atlantis abutments you've been working with, you won't find convex abutment designs. So they are also always very nice concave. They start from the implant shoulder, and then they go up smoothly, and then they go wider, but they are not going wide directly from the implant shoulder towards the bone, which is very important. So this is a case we restored with an Atlantis abutment, a case where a GBR procedure was performed, and then afterwards a connective tissue graft. And this is the final restoration. And here you see a very nice design, a very nice, enough space that is provided for a very nice emergence profile. But it's not only about abutment design, it's also about the timing of abutments. And more we now see the shift towards immediate abutment installation. And this is because of the fact that this is also evidence-based, that disconnection and reconnection of abutments, every time you do that, you will disturb the environment around the implants, and that will cause bone loss. This is a very nice study from the group of Mariano Sanz in Spain, where they compared implants that were provided immediately with the final abutment, compared with implants where healing abutments were used during a long time and connected and disconnected several times. And you see that the bone adaptations or the bone loss around the implants with the healing abutments, the bone loss was twice as high compared to implants that were restored with a final abutment immediately. And this is also the conclusion from this review and meta-analysis from the group from Kututsis. So where he concludes that abutment disconnection and reconnection significantly affects peri-implant marginal bone levels. And so these findings pave the way for revisiting current restorative protocols at the restorative treatment planning stage to prevent incipient marginal bone loss. And this is really important because I will show you later data from one of my PhD students, from Simon Windahl, where Simon discovered that already 0.5 millimeter of bone loss during the first year after implant installation is a predictor for future peri-implantitis development. So we have to try to give our patients a very clean start, a perfect start, a start without bone loss. So these are all cases that were treated in my private practice, where the uni abutments in those multiple unit restorations are always installed at the time of implant installation, or in cases where we have to adopt a submerged healing, then abutments are installed at the time of second stage surgery. And then the restorative dentist can work very conveniently on abutment level without disturbing the environment of the bone around the implant. Of course, not every implant is the same. So I had a look at a lot of single cases I've been treating with AstraTech EV, and mainly the anterior cases where we work with provisional restorations. The provisional restoration sometimes need to be adapted quite a few times to place some pressure on the soft tissues, to guide the soft tissues towards the ideal level, for instance, and then it's quite possible that you have to disconnect the provisional crown 3, 4, 5 times before we are happy with soft tissue management. But you don't see bone loss beyond a certain level when you do that. And of course we have the platform sheets and we have the smooth implant color on the AstraTech EV implant. So that means that basically when you remove the provisional, you don't lose the entire soft tissue attachment. So you still have attachment on that smooth color. But of course, preferably you want more. This is only 0.5 millimeter, so it's not much, but still you're not losing the entire soft tissue connection, which make it a very suitable implant for those indications. So then we come at our responsibility as a surgeon, as a prosthodontist. Let me share you a case of one of our students at Ghent University, a case that was treated with a supervisor that is not working with AstraTech in his private practice. And of course, you have to be careful when EV implants are installed, because it's a cylindrical implant. It's also a cylindrical implant with rather blunt threads. And when we install an implant and we aim for primary stability, you get your primary stability through compression, through bone condensation. And of course, you have to be careful not to overdo the bone. If you place too much pressure on the bone, you have a risk of necrosis. So this is a typical case of an unexperienced AstraTech user that is placing an implant. And when, of course, your implant motor is set at 35 Newton centimeters and the implant gets stuck in the osteotomy, and that means that there's too much compression. So what you should do then, of course, is remove the implant, make the osteotomy a little bit wider, and reinstall the abutment. Now, if you don't do that, and if you take your torque wrench, forcing the implant down at 50 Newton centimeters, of course, then you are at risk of causing terrible problems to your patients. And this is exactly what happened here in this case. So patient complained a lot about postoperative pain, which is obviously for a single tooth replacement not normal. And then at 10 days, there was an X-ray taken, and they already saw the bone disappearing. And this is a second major mistake that was made in this case. It was not only the surgery, but also at that 10-day control, when you see the bone disappearing around the implant, you see that the bone necrosis occurs, then of course you should immediately set a step back and remove the implant. So this was not done, so the implant was left in place for over a month, and then of course you get you get a view you don't want to see, and of course then the implant had to be removed. People can't blame the implant for a clinical situation like this. This is, of course, the responsibility of the practitioner. And a proper implant installation will not harm your patient, and you won't see things like this. So please be careful with the EV implant, not to apply very high insertion torque values. You need to understand the macro design of the implant you are working with, and if you set the implant motor at 25 Newton centimeters, then of course nothing will happen, and you won't see cases like this, because even the best implant can fail when it's not installed in the correct manner. Now, the drill protocol, there are a lot of options. It's a set with a lot of drills. You get, of course, the standard drills, drill 1, 2, 3, 4. But then, of course, you also have the cortical drills, drill A, drill B, where you can widen the osteotomy. You have the V drill, where you can remove in the apical part a little bit more bone. You have the X drill. So there are a lot of possibilities. And really all the tools are available in the set to being able to install the implant, let's say at 25 Newton centimeters in the majority of all cases. And sometimes when you encounter really soft bone quality, or in cases for extraction socket cases, for instance, then it might be a little more difficult to achieve high insertion torque or sufficient insertion torque to continue with an immediate loading procedure. But then, of course, we have a new innovation coming up, which I will show you later during this presentation, a new macro design, a new implant that can help you to treat those patients in a very predictable way as well. So this study by Luigi Canullo was quite an eye-opener for me, and it clearly shows that in 70% of the cases, we as practitioners, surgeons and prosthodontists, we are available for peri-implant disease. Only 30% of the cases is purely plaque-induced, and there you can blame your patients. But let's say that over 70% of those cases can be avoided if clinicians are doing a proper job. Now, one of the major factors affecting implant treatment outcome is, of course, malpositioning. Now, if you install the implant towards the buccal, or if implants are not installed deep enough, of course, then that will induce peri-implant disease. And this was already described by Bruno Collard and Hugo de Bruyn in 2002. So they saw during during a follow-up study, bone loss occurring around implants with short abutments. And those cases were all immediate loading cases. So that means implants were restored immediately after implant installation. And of course, short abutments are installed in cases with thin soft tissues. So they described already that the width of mucosal attachment, of course, is determined by biology, and bone loss may occur to establish biologic width or to re-establish it once you get the connection between the bone and the oral cavity. And this is also what we saw during a follow-up study in the Netherlands, where we evaluated overdenture patients. And we saw a lot of cases like this. So one implant with a short abutment, one implant with a long abutment in the same patient. And very consistently, the implant with the short abutment presenting more bone loss compared with the implant with a long abutment. But what was even more striking was that when you made the sum of the bone loss and the height of the abutment, the dimensions were quite stable. You always ended up with a 3 to 4 millimeter dimension. And these were the findings. So we calculated, or we estimated the bone loss around implants installed with 2 millimeter implants compared with implants installed with 4 millimeter abutments. And very consistently, this resulted in more bone loss of 1.70 millimeters at 1 year for the short abutments, and even increasing afterwards towards 1.23 millimeter after 2 years. When we had a look at implant success, then we saw that implants installed with 4 millimeter abutments or even longer abutments, all implants were considered successful, whereas short abutments so implants with abutments of less than 2 millimeter, only 1/3 of the implants were successful. So that means that a lot of bone loss in those cases was caused just by biology. So those findings were retrospective findings. So we did the same thing in a prospective study, where we installed one implant just echicrestally, without having the soft tissue thickness into account, and then a second implant, as you can see in the lower left corner. One implant was intentionally installed deeper, providing enough space, meaning 3 to 4 millimeters for biologic width establishment. So we measured soft tissue thickness. The mean soft tissue thickness was more or less 1.9 millimeters, and so rather thin soft tissues. Everything that's less than 2 millimeters considered rather thin, and those were our findings. So you see bone loss or bone adaptations occurring in around both implants. But the major difference is that you have one implant that is completely surrounded by the crestal bone after bone remodeling, and then one implant where you get exposure of the rough implant surface in the oral cavity with possible contamination, of course, afterwards. And then, of course, you have other risk factors coming in. So this is a long-term follow-up study. And here you see one significant factor affecting bone loss after 1 year, which is abutment height. So basically means biologic width establishment. And then, of course, after 9 years, you see other well-known risk factors coming in, such as smoking and history of periodontitis. And so you see, well, let's skip this one, but you see the cumulative effects even. So the smoking and history of periodontitis when you combine the two risk factors in one patient, those are the patients really suffering from peri-implantitis, especially when they got a bad start, especially when they had already bone loss from the first year. And this is what typically one of those cases. You see implants with short abutments. You see bone loss after 1 year already. That remained stable. At the 2-year follow-up, there was not of no additional bone loss seen around the implants. But then the patient disappeared and only came back 9 years later, and then you see a very big disaster. So she was a heavy smoker. She got a periodontal disease. She wasn't compliant at all, so a lot of plaque, but she definitely got a bad start. And this is what we should avoid. And this is a very nice paper by Simon. Simon is finishing his PhD. I hope he can conclude his work during the first months coming. But when we have a look here at the results, you see here that early bone loss of 1.5, 1 and 2 millimeter, that those were significant predictors for peri-implantitis and implant loss after 10 years. With implants experiencing early bone loss of more than 0.5 millimeter during the first years, they showed a 5.43 times higher odds for future peri-implantitis development. And then again, probability in developing peri-implantitis was 52% when smoking, periodontal history, and early bone loss exceeding 0.5 millimeter were combined. So when those three factors are present, the three of them, then you have a 50% probability of developing peri-implantitis, which is huge, of course. All right, so then we will finish with the current trends, with let's say the shift towards digital implant dentistry. And I show you this case I showed you before, but this is typically a case where we combine intraoral scans and CBCT images in order to be able to make a proper planning right from the start, to be able to go for immediate loading procedures, immediate restoration, using the final abutment immediately whenever possible. So this was a case that we treated with Azento. When you use Azento, you send the intraoral scans and CBCT scans to the planners of Dentsply Sirona implants, and they make the treatment plan for you. They make the design of the abutment, and of course you can make some minor adaptations whenever that's necessary. And then of course you get this box with the guide, with the implant, with the drills, with the final abutment and the temporary restoration. And then, of course, it's an easy surgery to perform once a nice planning is made. Tooth extraction. This was also a case where we used an angulated screw access abutment to be able to screw retain. So what's the available evidence to work guided? So there's a lot of evidence that when we use guides, that we can work much more precise. This is a very nice study from Faris Younes, where he compared free-handed surgery to pilot drill guide surgery and safe guide surgery or fully guided surgery. So a comparison was made after the implant was installed. So a new CBCT image was made, and that was compared to the implant planning that was made. And you see that using a fully guided surgery, you only get a mean deviation of less than 1 millimeter compared to more than 2 millimeters when you work free-handed. But when you also have a look at the maximum deviation, then you see when free-handed implants were placed, deviations of nearly 5 millimeters. which is of course not acceptable. But from a clinical point of view, what's might be more important, that is, although all crowns could be screw retained, so this was determined based on the planning on CBCT. Now, when free-handed surgery was used, although it was possible to screw retain, after the implant was installed, the lab said, listen, this is not possible to go for a screw retained restoration. We have to cement the crown. And when you work fully guided, of course, all implants could be restored with screw retained restorations. So this is also, let's say, a factor that that favors, of course, guided surgery. So this is then the final abutment with the temporary crown, 3 months after implant installation. You see a very nice adaptation of the soft tissues. And then, of course, we have to transfer the situation to a final restoration. So the final crown that is made by the lab is sent to us, and then of course you have to remove the abutment once to be able to cement the final restoration on the Atlantis abutment outside the mouth to be able to control cement access, and then of course you can immediately reinstall the final restoration in the patients, as you can see here with a perfect adaptation of the crestal bone, let's say here 6 months after implant installation. So I promised, I'm sorry, I promised to show you this implant, which is the latest development of AstraTech. So this is the prime taper implant that was launched at the EAO meeting in September. And this is an implant which, again, wears all the features of the EV implant. So we still have the micro threads, we still have the same EV connection. So it's the conical connection with the platform shift, and we still have the OsseoSpeed implant. Now, what they did here is they changed the thread design. So now we have cutting threads, cutting flutes, and we have a tapered implant. And of course, this is an ideal implant to secure a primary stability in more demanding cases, such as immediate loading cases, and a case like this, immediate placement and immediate loading cases. So this was done free-handed. So the tooth was removed, then the implant was installed in contact with the palatal wall. As we know, following tooth extraction, important resorption reactions occur. And we graft, of course, also the buccal gap. You really want to have a volume stable material in the gap to reduce or to minimize resorption of the buccal contour as much as possible. And then, of course, we go for an intraoral scan, which is in such case, of course, a tremendous advantage over conventional impressions. As you can see here, the gap is grafted, so as you got the impression paste that comes in contact with the graft, which is not really an ideal situation. So the digital impression is made, sent to the lab, and the day after we receive the provisionals, which can be installed then directly to give the patient function immediately. So what's the scientific rationale about this macro design? If we have a look at condensation, condensation increases peri-implant bone density, but also the strains at the interface. And if you place too much pressure on the bone, this will cause micro damage, and micro damage can result in of course, necrosis of the bone. But what we also see is that condensation will give rise to a higher insertion torque, but a higher insertion torque is not the same as higher primary stability. And this is a very nice study by Stig Hansson, where they had a look and compared cutting implants with bone condensing implants in a laboratory bone model. So they measured insertion torque values, ISQ values, and then the circumferential tensile strains on the bone. And what is rather striking is that condensing implants give rise to a higher insertion torque, while the ISQ value is comparable compared with the cutting design. So that means that the condensing implant will not be more stable into the bone. Will only have more compression and a more risk of necrosis. So that means for cases, those selective cases where you're definitely in need of having a sufficient primary stability, a cutting implant such as this new prime taper implant will make your life much more easy for those cases. And of course, we don't only have the novel implant design, but we also have the intraoral scanning techniques using PrimeScan. So with PrimeScan, the PrimeScan is collecting 5 times more data, which makes it a lot faster, but also a lot more precise. These are new data from the group of Professor Van de Wege from Rani Daze, which is also working on a PhD. Here you can see that using the new PrimeScan software, and especially when you work on abutment level, you can see that even for full arch reconstructions, digital impressions or digital scans are as accurate as the analog models we have today available. So there's basically, this means that there's no reason anymore to go for conventional or analog impressions anymore. So you can safely use and very predictably use intraoral scans using PrimeScan for all restorations, all implant supported restorations. So let me show you a case of Stefan. So a case where 5 implants were installed on abutment level, and then the intraoral scans are made. So you basically make a scan with the scan bodies on the implant, and you make a scan also of the prosthesis. You make a scan with the prosthesis over the scan bodies, and then also you can in the same way you can use the bite registration. So you ask the patient to close, and you have all the information available, and then you get some kind of try-in back from the lab. The try-in can be used to verify the midline, to verify occlusion, to make some minor adaptations whenever that's necessary. And once, of course, you have let's say the perfect try-in, it goes back to the lab, and the lab can then make the final restoration, as you can see here. So this works fast. This works very precise. You will definitely increase your accuracy, and also for the patients, it's a rather a game changer not to have the conventional impressions anymore. So I think, well, we're in nearly 1 hour, so that's good. So I hope I was able to show you the evidence behind the Astrotech implant system. I hope that was also possible to show you that the new innovations, they are still very important. I think we can safely treat every indication today in a very predictable way. And I also think that the digital workflows are very important and have really changed the way we are treating our patients today. It has tremendously increased predictability and accuracy, and we are today able to restore our patients in a let's say a very fast way, offering them aesthetics and comfort straight away. So with this message, I would like to thank you for your kind attention. And if there are any questions, I will be more than happy to answer them.
Thank you so much, Stijn, for this really interesting and nice presentation. As we have no questions, I will close this webinar, and I wish all of you a nice continuation of your day. Bye-bye and see you soon.
Thank you. Bye-bye.